السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الثانية جامعة بابل كلية الصيدلة. Our topic today is thyroid hormone. Thyroid gland is a shield-shaped structure located immediately below the larynx in the anterior middle portion of the neck. It is composed of large number of tiny sac-like structures called follicles. These are the basic functional unit of the thyroid gland. Thyroid gland is a highly vascular structure. It receives about 4 to 6 ml per gram per minute of blood. It has sympathetic innervation. Embryologically, the thyroid gland began development in the 4th week of intrauterine life. Hormones secreted from the gland at about 12 weeks of intrauterine life. Fetal thyroid hormones are useful for normal fetal bone maturation and for the normal development of central nervous system. Anatomically, each follicle is formed by a single layer of epithelial or follicular cells and is filled with a secretory substances called colloid. The colloid consists largely of glycoprotein iodine complex called thyroglobulin. So, thyroglobulin is composed of glycoprotein which is complex to iodine, forming thyroglobulin. The thyroglobulin that fills thyroid follicles contain 140 tyrosine amino acids. Most of the iodide in the body is secreted by the kidney. Only 1/5 of the body iodide is selectively removed from the circulation by the cells of thyroid gland for the synthesis of thyroid hormones. This is done by specific active pump and the process called iodide trapping of iodide to the thyroid gland, achieved by specific active pump that will take the iodide from the circulation into the thyroid cells. The thyroid is remarkably efficient in its use of iodide. A daily absorption of 100 to 200 microgram of dietary iodide is sufficient to form normal quantities of thyroid hormone. In the process of removing it from the blood and storing it for future use, iodide is pumped into the follicular cells against a concentration gradient. As a result, the concentration of iodide in the normal thyroid gland is approximately 30 times that in blood. 30 times more iodide is present in the thyroid gland than in blood. In the process of thyroxine synthesis, iodine is attached to these tyrosine amino acids. Both thyroglobulin and iodide are secreted into the colloid of the follicle by the follicular cells. As you see here in this figure, the follicles of the thyroid gland are filled with the colloid. Where the follicle cells produce the thyroglobulin. So, the first step in the formation of thyroid hormone is production of thyroglobulin. Thyroglobulin is synthesized on the rough endoplasmic reticulum and Golgi apparatus of thyroid follicular cells. Thyroglobulin is then packaged into secretory vesicles and extruded into the follicular lumen. Later, the tyrosine amino acid residue of the thyroglobulin will be iodinated to form the precursor of thyroid hormone. This figure will help you to understand the stages of thyroid hormone synthesis. The second stage in the formation of thyroid hormone synthesis is sodium iodine co-transport. Iodine is actively transported from the blood into the follicular epithelial cells against both chemical and electrical gradients. The activity of this pump is regulated by the level of iodine in the body. For example, low level of iodine due to dietary deficiency will stimulate the pump to increase transport of iodine. If the dietary deficiency is severe, however, even the sodium iodide co-transport cannot compensate and the synthesis of thyroid hormone will be decreased. There are several competitive inhibitors of these co-transport mechanisms, including the anions, thiocyanate, and perchlorate, which block the iodine uptake into the follicular cells and interfere with the synthesis of thyroid hormone. Another figure will help you to understand the stages of thyroid hormone formation. I hope you take your time to understand these stages. The third stage in the formation of thyroid hormone is the oxidation of iodine to iodide. Once the iodine is pumped into the cell, it is oxidized into the iodide by the enzyme thyroid peroxidase. Thyroid peroxidase enzyme will catalyze the oxidation and the next two steps, which is the organification of the iodide into thyroglobulin and the coupling reaction. Thyroid peroxidase is inhibited by propylthiouracil, which block the synthesis of thyroid hormone by blocking all of the steps catalyzed by the thyroid peroxidase enzyme. Thus, administration of propylthiouracil is an effective treatment for hyperthyroidism. A fourth step required for formation of thyroid hormone is organification of iodide. When iodide is combined with the tyrosine moietase of the thyroglobulin, catalyzed by the thyroid peroxidase to form monoiodotyrosine and diiodotyrosine. The monoiodotyrosine and the diiodotyrosine remain attached to the thyroglobulin in the follicular lumen until the thyroid gland is stimulated to secrete thyroid hormones. A high level of iodide inhibits organification and synthesis of thyroid hormone, which is known as a Wolff-Chaikoff effect. Result from a high level of iodine which inhibit organification, which is the fourth stage of thyroid hormone formation, will inhibit the organification and the synthesis of thyroid hormones. Another figure will help you to understand the stages of thyroid hormone production. The fifth stage is the coupling reaction. A two separate coupling reaction occur between the monoiodotyrosine and the diiodotyrosine, again catalyzed by the thyroid peroxidase enzyme. In one reaction, two molecules of DIT combine to form T4 hormone. In the other reaction, one molecule of DIT combine with one molecule of MIT to form T3 thyroid hormone. A portion of monoiodotyrosine and diiodotyrosine does not couple, which is called the leftover, will not undergo the coupling reaction and simply remain attached to the thyroglobulin. The iodinated thyroglobulin is stored in the follicular lumen as a colloid until the thyroid gland is stimulated to secrete its hormones. Another step in the production and formation of thyroid hormone is endocytosis of thyroglobulin. When the thyroid gland is stimulated, iodinated thyroglobulin with its attached T4 and T3 monoiodo and diiodotyrosine is endocytosed into the follicular epithelial cells. Once inside the follicular cells, thyroglobulin is transported in the direction of the basal membrane by microtubular action. Now we pass to the seventh stage, which is the hydrolysis of T4 and T3 from thyroglobulin, as we said in the last slide. By lysosomal enzyme to release T4 and T3 monoiodo and diiodotyrosine from the thyroglobulin to be used for production of thyroid hormone or to be released from the gland to the circulation. T4 and T3 are transported across the basal membrane into the nearby capillaries to be delivered to the systemic circulation. The monoiodo and diiodotyrosine remain in the follicular cells and are recycled into the synthesis of new thyroglobulin. Deiodination of monoiodo and diiodotyrosine inside the follicular cells by the enzyme thyroid deiodinase enzyme. So, the iodine that is generated by this step is recycled into the intracellular pool and added to the iodine transported by the pump from the circulation. The tyrosine molecule are incorporated into the synthesis of a new thyroglobulin to begin another cycle. Thus, both iodine and tyrosine are salvaged by the deiodinase enzyme. Deficiency of thyroid deiodinase, therefore mimic dietary iodine deficiency because it will cause decrease the iodine present for the production of thyroid hormones. I like this figure because it is the most easable one that demonstrates the production of thyroid hormone. As you see, the first step is the production of thyroglobulin. The second is the entrance of iodine to the thyroid follicular cells by the active pump mechanism. The iodine will pass through the effect of peroxidase enzyme into the iodide. Iodide will complex with the thyroglobulin under the effect of organification by the peroxidase enzyme. So the monoiodo and the diiodothyronine will produced and they are attached to the thyroglobulin. Okay, this is in the follicular lumen of the follicular cells. These are the follicular cells of the thyroid gland, and this is the follicular lumen where the thyroid hormones are preserved. Coupling reaction occur under the effects of peroxidase enzyme to produce the T4 and T3, and in the presence of the MIT and DIT, they are all complex to the thyroglobulin in the follicular lumen. By the way, in the sixth stage, endocytosis of these thyroid hormones occur into the follicular cells. From the follicular lumen, these hormones will pass with the thyroglobulin into the follicular cells. When the thyroid gland is stimulated, the thyroglobulin thyroid hormones complex will detached, result in passing of T3 and T4 into the circulation. What is remain is the MIT and the DIT and the thyroglobulin. They will pass through the thyroid follicular cell and they will undergo deiodination process, return to its precursors, which are the tyrosine amino acids that will form the thyroglobulin, okay, and the iodine, which will pass into the follicular lumen to form the iodide under the effects of peroxidase enzyme. It is a vicious circle that help in the continuation of thyroid hormone secretion. Only T4 and T3 thyroid hormone will be released into the circulation in a percentage of 93% for the T4 and 7% for the T3. There is evidence that T3 is the active form of thyroid hormone and that T4 is converted into the T3 before it can act physiologically in our cells. A comparison between the thyroid hormones T3 and T4 will give you an attention to their potency, rate of secretion, onset of action, the half-life, storage, and inactivation. As you see, the half-life of T3 is 3 days, while the half-life of T4 is 7 days. Comparison between the two hormones about the function and the stimulation. No response to thyroxine occur in the testes, uterus, lymph nodes, spleen, and anterior pituitary gland. Otherwise, all cells in the body are under the control of thyroid hormone. Thyroid hormones are bound to thyroid binding globulin and other plasma proteins for transport in the blood. Only the free hormone enters cells and regulates the pituitary feedback mechanism. There are three major thyroid binding proteins: the thyroid hormone binding globulin, the thyroxine binding prealbumin and albumin. Almost 99% of T3 is bounded to the thyroid hormone binding globulin. The secretion of thyroid hormone is regulated by the hypothalamic pituitary thyroid feedback system. In this system, thyrotropin releasing hormone, which is produced by the hypothalamus, controls the release of thyroid stimulating hormone from the anterior pituitary gland. Thus, thyroid stimulating hormone in turn increases the overall activity of thyroid gland by promoting the release of thyroid hormone into the bloodstream and increase T4 and T3 synthesis. Regulation of thyroid function is demonstrated in this figure with the target cell throughout the body. The major secretory product of thyroid gland is T4, which is not the most active form of thyroid hormone. This problem is solved in the target tissue by the enzyme 5-iodinase, which converts T4 into T3 by removing one atom of iodine. The target tissue also converts portion of T4 into reversed T3, which is inactive form of T3. Essentially, T4 serves as a precursor for T3 in the circulation, and the relative amounts of T4 converted to T3 and reverse T3 determine how much active hormone is produced in the target tissue. What is the major effects of thyroid hormone, I mean T3, on various organs in our body? First and most important is the basal metabolic rate. One of the most significant and pronounced effects of thyroid hormone is increased oxygen consumption and the resulting increase in basal metabolic rate and body temperature. Also, increased oxygen consumption depends on increased availability of substrates of oxidative metabolism. Thyroid hormone increases glucose absorption from the gastrointestinal tract, potentiate the effect of other hormones like catecholamine, glucagon, growth hormone on gluconeogenesis, lipolysis, and proteolysis. Thyroid hormone increase both protein synthesis and degradation, but overall their effect is catabolic. Net degradation, which results in decreased muscle mass. On cardiovascular and respiratory, because thyroid hormone increase oxygen consumption, they create a high demand for oxygen in the tissue. Increasing oxygen delivery to the tissue is possible because thyroid hormone produce increase in cardiac output and ventilation. The increase in cardiac output is the result of combination of increased heart rate and increased stroke volume. These cardiac effects are explained by the fact that thyroid hormone induces the synthesis of cardiac beta-1 adrenergic receptor. You will understand these receptors in the pharmacology next. Growth. Thyroid hormone is required for growth to adult stature. thyroid hormone act synergistically with the growth hormone and somatomedins to promote bone formation. Thyroid hormone promote ossification and diffusion of bony plates and bone maturation. On central nervous system, thyroid hormone have multiple effects on the CNS, and impact of these effects is age dependent. In the perinatal period, thyroid hormone is essential for normal maturation of the CNS. Hypothyroidism in the perinatal period causes irreversible mental retardation. For this reason, secretion of newborns for hypothyroidism is mandatory. On the autonomic nervous system, thyroid hormone interact with the sympathetic nervous system in ways that are not fully understood. Many of the effects of thyroid hormone on the basal metabolic rate, heat production, heart rate, stroke volume are similar to those produced by catecholamine via the beta-adrenergic receptors. The effects of thyroid hormones and catecholamines on the heat production, cardiac output, lipolysis, and glucogenogenesis appears to be synergistic. You can see and understand the effect of thyroid hormone, which will act on each cell in our body for synthesis of new proteins that will act on the growth, CNS development, cardiovascular system, and on metabolism. Well, is there any abnormalities of thyroid secretion? Yes. Hyperthyroidism is the most common form of thyroid hormone abnormalities. A disease called Graves' disease is an autoimmune disorder that characterized by increased circulatory level of thyroid-stimulating immunoglobulin. These immunoglobulins are antibodies to thyroid stimulatory hormone receptors on the thyroid follicular cells. When present, these antibodies intensely stimulate the thyroid gland, result in increased secretion of thyroid hormone and hypertrophy of the gland. Other causes of hyperthyroidism are thyroid neoplasia, excessive secretion of TRH and TSH, and administration of excessive amounts of exogenous thyroid hormone. As a drug. If we take thyroid hormone in on high amount. This figure demonstrates how the thyroid stimulating antibodies act on the receptors of thyroid stimulating hormones that are present on the cells of thyroid gland. They will activate these receptors and stimulate the synthesis of thyroid hormone by the thyroid gland and result in unregulated overproduction of thyroid hormone from the gland. For the diagnosis of hyperthyroidism, it is based on symptoms and measurements of increased level of T3 and T4. If the cause of hyperthyroidism is Graves' disease, thyroid neoplasm, the disorder is in the thyroid gland, or if it is due to exogenous administration of high level of thyroid hormone that results in hyperthyroidism, then the TSH level will be decreased. However, if the cause of hyperthyroidism is increased secretion of the thyrotropin releasing hormone or the thyroid stimulating hormone, the disorder is in the hypothalamus, not in the thyroid gland or in the anterior pituitary gland, then the thyroid stimulating hormone level will be increased. If the cause is in the hyperthyroidism is due to a defect in the hypothalamus or in the anterior pituitary gland, then the thyroid stimulating hormone level will be increased. While if the defect that cause hyperthyroidism is in the gland itself due to Graves' disease or due to thyroid neoplasm, then the TSH level, the thyroid stimulating hormone level, will be decreased. This is how we can differentiate between the causes of hyperthyroidism by investigating the level of thyroid stimulating hormone. If you look to this picture of a young lady, you will see abnormally enlarged tumor in her neck. Increased activity of thyroid gland can cause it to enlarge. This enlargement of thyroid gland is called goiter. The goiter may compress the esophagus and cause difficulty in swallowing. For treatment of hypothyroidism, we will give the patient drugs that will inhibit synthesis of thyroid hormone, like propylthiouracil, or we do surgical removal of the gland or radioactive ablation of the gland with iodine 131. Another sign of hyperthyroidism is exophthalmos. Exophthalmos is a protruding of eye outwards due to edematous swelling of the retroorbital tissue, and degenerative changes in the extraocular muscles lead to stretching of the optic nerve, result in damage of vision, dryness, irritation, infection, or even ulceration of the cornea, and it may be severe in 1/3 of hyperthyroidism. Now, we can move to hypothyroidism. Hypothyroidism is decreased or deficient secretion of thyroid hormones, which may be primary hypothyroidism due to defect lies within the thyroid gland itself due to iodide deficiency, dietary deficiency, congenital thyroid enzyme deficiencies, or inflammation of the gland. The low T3 and T4 level lead to elevated TSH level, and this stimulates the enlargement of the thyroid gland and a goiter formation. Secondary hypothyroidism occur due to deficiency of the thyroid stimulating hormone from the anterior pituitary. This leads to thyroid atrophy rather than goiter. Another term in this lecture is myxedema. Don't forget goiter, exophthalmos, and myxedema. Myxedema is a diffuse non-pitting edema which lead to bagginess under the eye and the swelling of the face due to increased quantity of hyaluronic acid and chondroitin sulfate bound with the protein from excessive tissue gel in the interstitial space, and because of the gel nature of excess fluid, it is mainly immobile and the edema is non-pitting. It occurs in those who has almost total lack of thyroid hormone function. How we can treat a patient with hypothyroidism? Simply by giving thyroxine tablets. This figure, you can see man before and after before and after hypothyroidism. How the effect of myxedema change his features. You can see this figure to understand the differences in the signs and symptoms of hyperthyroidism and hypothyroidism. You can see that goiter, which is enlargement of the thyroid gland, can occur in patient with hyperthyroidism or in patient with hypothyroidism. So goiter is not a significant sign in patient with abnormal thyroid function. It can occur in a patient with hyperthyroidism or even in a patient with hypothyroidism. This figure demonstrates a plan for investigating a patient with thyroid abnormalities. Normal levels of T3 and T4 and how they are changed during hyper and hypothyroidism. We will pass to another topic, which is cretinism. Cretinism is a severe hypothyroidism which occurs during fetal life, not during childhood or adulthood. It occurs during fetal life, infancy or childhood, not during adulthood. Cretinism is a hypothyroidism that occurs during fetal life, infancy or childhood. The cause may be congenital lack of thyroid gland, or failure to produce thyroid hormone due to genetic defects in one or other enzymes of the gland, or the lack of iodine in the diet due to endemic cretinism. Cretinism characterized by failure of the body growth and mental retardation. So the baby will have this look. Skeletal growth affected more than soft tissue, which enlarge excessively. Child become obese, stocky, short appearance, large tongue that may affect swallowing and breathing and lead to choking. Treatment at any time is with iodine and thyroxine. Normal physical growth may achieve, but not mental, unless given in early weeks after birth, which is called permanent retardation. Thank you very much for your listening. I hope to see you in the next lecture.